Welcome back. My name is Lynette Franklin, and we're continuing on in the Continence module, looking at Section 2, page 22, Incontinence, classification of established urinary incontinence. So just review, remember what normal voiding physiology is. It's a coordinated effort between the brain, the spinal cord, the pons, the sympathetic and parasympathetic and somatic nervous systems, with the bladder and the pelvic floor, the sphincter. This coordinated action helps to void at socially appropriate times. This coordinated action, when it's all working together, is called physiological voiding. If it's normal, everything works. You fill, you empty. The bladder either is at rest and filling or squeezing and emptying. At times, though, there can be reversible factors that actually impact the ability of the bladder to empty and fill at coordinated times. These reversible factors are transient and can be addressed with minute or management that is very specific. These are excuse me. These factors are elicited in the numeric diapers, D-I-A-P-P-E-R-S. Delirium, infection irritants, atrophic vaginitis, psychological issues, pharmacological issues, excess urine production, restricted mobility, and stool impaction. They can also be augmented with reversible factors such as don't sleep or sleep nautria, also with reversible factors such as urinary retention or endocrine issues. So it's important to be aware of these issues, and every time that you're addressing somebody who has continence issues, to look at each of these factors and evaluate whether or not this factor is appropriate to be evaluated and treated. This is a helpful hint for your learning exercises. When you're looking at the reversible factors, we ask you to look at each of these letters and evaluate whether or not that letter or that factor is part of the equation when evaluating a patient with incontinence. There's also the difference between voiding dysfunction and incontinence. Incontinence is the voluntary loss of urine or feces when not expected, whereas dysfunction is troublesome problems without the leakage. For example, you may have urgency and frequency or nautria, getting up many times at night to go to the toilet, but you're actually never incontinent. You make it to the toilet socially appropriately. It's just the frequency and urgency to have to void is troublesome. So now we're going to look at classification of established or chronic urinary retention. We're starting on page 22 in your module. This is looking at a pattern of incontinence that's not associated with reversible factors. So the reversible factors have all been addressed and corrected, and the incontinence is continuing. This pattern is very specific, and it can be due to different causative factors. So when you think of the bladder and the pelvic floor, remember they're working together, there can actually be failure to store, or you leak. This can be secondary to the bladder or to the sphincter. If it's a bladder is failing to store, it means the bladder is not contracting appropriately, or it's contracting inappropriately, not at a socially acceptable time. Or it may be due to the sphincter. This, if it's failing to store, the resistance of the sphincter is less than that of the bladder pressure. Then we have failure to empty or retention. This may be due to the bladder. The contractions are not adequately or sustained long enough to empty effectively, or the sphincter has excessive urethral resistance and does not allow it to empty. This is really excellent, and it helps sort of delineate whether it's a bladder problem or a sphincter problem. But remember, when normal voiding physiology, it's just not the bladder and sphincter in concert by themselves. We also have to have the brain, the pons, and the spinal cord interaction. So it may be a component of the function of the reservoir, it may be a component of the sphincter, or it may also be a component of a complex neurological factors that affect the ability and the coordination between the brain and the bladder. So there's actually some more delineations, and we will discuss those here. The current classification system for failure to store or stress incontinence, which is leakage due to the sphincter not working. It's a storage problem. So then there's overactive bladder. What happens here is the bladder is squeezing when it's not socially appropriate. Functional incontinence is a cognitive or a mobility issue. The person is not able to interpret what the message is from the brain to the bladder, and or is not able to physically make it to the toilet in a timely manner. Enuresis is failure to wake up with a full bladder and actually wet the bed or wet whatever you're sleeping on in a form of sleeplessness. Failure to empty is retention. Reflex or neurogenic bladder is a complex problem with the emptying and leakage secondary to a neurologic lesion. When you look at page 23, we have these all listed. Also in your appendices, we have the International Continence Society recommendations and evaluation. On page 186, it actually is the title page and the web access for the International Consultation on Incontinence. If you ever have an opportunity to be a member of a task force or a consultation, this is it. Every 5 years, this group meets in Paris and reviews the current literature and evidence-based practices for incontinence and voiding dysfunction. On page 187 is their latest definition of incontinence. These definitions I provided because they add a different way of looking at the same things that we've talked about, and that might be relevant to help you in your studying. So let's discuss first stress urinary incontinence. What we're going to do is broadly look over the pathology, the presentation, and treatment options. The treatment options are just going to be basically reviewed at this section of the module, and then we'll go into deeper detail after we address management in a future section. So stress urinary incontinence is a problem with the sphincter. The bladder is not stressed out or anxious, or is the pelvic floor. What's actually happening here is when there's any stress, for example, or any abdominal increase in pressure or interthoracic pressure, the sphincter dysfunction and does not remain closed. So this would happen when there's leakage with increased abdominal pressure. So let's think of times when there's increased abdominal pressure. Coughing, sneezing. The person may bend down and lift up a baby or a laundry basket. They may be jogging, and the increased pressure of the stride on cement actually causes leakage. So this is stress on, physical stress on the sphincter helps to produce this type of incontinence. What's happening is at this point the bladder is at rest, and there's not a lot of the bladder's at rest, so normally the sphincter should remain closed. The sphincter is closed, but because the abdominal pressure is so great, it overcomes the resistance of the sphincter and it actually opens incorrectly. So when we think about this, what causes it? There's a couple of different etiological problems. The first one is sphincter dysfunction. This is inadequate urethral resistance, and this permits leakage of urine in the absence of a bladder contraction. In women, this can be due secondary to urethral hypermobility. So if you think of the pelvis and the bladder and the pelvic organs all as one unit, you have the bladder. It's being suspended by the abdominal musculature. On the anterior and posterior aspect is the spinal cord, and then superior to the bladder, you have this hammock action of muscles. These muscles can become stretched, and the actual urethra, which passes through these muscles, becomes out of line or becomes hypermobile. In a man, a prostatectomy or removal of the prostate actually physically changes the architecture of the pelvic floor. Remember, the prostate, just distal to this, is the sphincter that controls urinary continence for men. And after the sphincter has been damaged secondary to a radical prostatectomy, they may have an open urethra that does not actually close adequately. Scar tissue can also happen right after the surgery and can actually cause occult symptoms of continence when actually the scar tissue is closing over the urethra, so they don't really see the incontinence right away. But when that scar tissue is removed, for example with catheterization or instrumentation, the scar tissue is removed and they actually also have stress urinary incontinence. There's then the other etiological factor is nerve damage to the pelvic floor or damage to these nerves. This can be secondary to a trauma like an open book pelvic fracture. It can be due to surgery, spinal cord injury, or meningeal as in patients with spina bifida. So let's look at the different types of incontinence with stress urinary incontinence. First of all, sphincter damage. First of all, when we have normal abdominal response, we should be able to cough and sneeze and have an infinite amount of abdominal pressure and our sphincter stays closed. So what happens when this fails? So as we get older, our pelvic floor muscles become weak. We have atrophic vaginitis, which actually decreases the coaptation of the urethra. And after multiple vaginal deliveries, actually it just takes one vaginal delivery to do the damage to the pelvic floor and nerves and ligaments. And so no longer is the bladder being suspended and the urethra is being suspended correctly. So with also a hysterectomy, there's potential problems for damage, and chronic straining from stool to have a stool can also cause damage. So as you can see in this diagram here, we have the bladder completely suspended in the pelvis adequately. It's actually the base of the bladder's at the top of the pubic symphysis, and it's all suspended where it should be. Here you can see the muscles are not in this diagram, but the bladder has actually descended and is no longer suspended adequately. So the urethra, as you can see here, is wide open and there's not the ability for it to be protected and controlled. So let's look at this another way. I'm just going to come up to the camera. This is another way of thinking about this. This is the bladder, and this is the bladder neck, and this is the urethra. When the pelvic muscles are intact, they hold it like this. And the urethra has a little bit of kink. So when you cough and sneeze, the urethra goes up just slightly, which causes a kink in the urethra, which causes increased resistance, which is exactly what happens with a man. He has a kink in his urethra, and the resistance for the urethra increases, so you won't leak. But when the pelvic floor becomes hypermobile, instead of the urethra being supported by the pelvic floor and kinking, it just is mobile and it just wiggles. And so there's no kink added in the urethra, and then it's a straight shot and they leak. So genuine stress urinary incontinence is secondary to weak pelvic floor and lack of support, permitting the urethra to move and urine to fall out. So how would we address this? First of all, there's strengthening pelvic floor exercises. These are considered Kegel exercises. Pessaries, which are an intravaginal device to actually physically put a kink in the urethra. And finally, surgical options to actually use a piece of tape or a sling to add urethral resistance. The second type of stress incontinence is intrinsic sphincter deficiency, and this can happen in men as well as in women. This is caused by severe muscle damage or weakness or loss of innervation to the sphincter muscles. And so what happens is there's just not the response. The nerves are not communicating with the muscle, or the muscle is so torn or damaged that it cannot actually close. What happens in this situation is it's the stovepipe urethra. Basically, the urethra doesn't even move. It's just straight open. So when the person is in a position like standing or anything like that, there's absolutely no coaptation of the urethra, and they'll just have a gush of urine. This is secondary to a chronic indwelling catheter that has actually eroded the sphincter. It could be due to the loss of elasticity of the urethra and scarring of the urethral lining. It could be due to a pelvic trauma where the nerves are no longer innervating the pelvic floor. It could be due to a neurological lesion causing denervations such as a spinal cord injury or a spina bifida. And it can also be done secondary to a radical prostatectomy, which is a lot of times where we see it in men. But with current surgeries such as robotic surgery and nerve-sparing prostatectomies, this is actually decreasing. The end result is that you have this rigid urethra that doesn't move, that doesn't close, and it has basically zero resistance, and you'll leak. So what are the symptoms of intrinsic sphincter deficiency? There's leakage with minimal abdominal increase. So somebody may just stand up and they have some leakage. And the leakage with any type of stress incontinence is not associated with the desire to void. So these people are just going along in their normal everyday business and they'll leak. So how do we diagnose stress urinary incontinence? Well, there's a couple of different things that we do. The paper towel test, the pad weight test, the Q-tip test, and then urethral pressure studies performed in conjunction with urodynamic studies. So let's look at each of these. First of all, the paper towel test. Using a blue chuck, the patient is disrobed and the chuck is placed on the floor underneath them. Or the patient remains robed and has a dry, clean incontinence pad placed in their drawers. The patient then does provocative maneuvers to try and elicit the stress incontinence response. So if they always leak when they're jogging, have them jog. If they leak when they're coughing, have them elicit a cough. It's a little bit difficult to make a sneeze, so a lot of times if you have them turn their head to the right and cough, that will elicit the same amount of pressure that a sneeze would elicit. If it's walking upstairs, if it's doing jumping jacks, you want to have them elicit this response. If they're disrobed, you want to be able to see the leakage from the urethra. You don't want them to have a strong desire to void because you want it just at rest. And you also want to test for this while they have some fluid in their bladder. So do not test it right after you've catheterized them or after they've gone to the toilet for a specimen. Leakage with activity confirms stress urinary incontinence, but does not demonstrate exactly what type of stress urinary incontinence they have. The next test is the paperweight test, and this test actually can look at the amount of pads somebody uses at home and elicit when they are leaking. So what you have the patient do is record for a 24 to 48 hour period how many pads that they actually use, and they take the used pads, place it in a sealed plastic bag such as a lockable Ziploc or some type of bag like that, and bring it into the clinic along with a dry pad of the same type. These pads are then weighed, the wet weight and the dry weight. The dry weight is multiplied by the number of pads used in the 48-hour period, and then they're subtracted and you find the actual wet weight of pad usage. This can help quantify how much leakage the patient has in a 24-hour period. The Q-tip test is actually a test that's a little bit more invasive and not quite tolerated as well. What you want to do is place the female in the lithotomy position with her back, lying on her back, her legs spread, and you're going to put a lubricated cotton tip applicator in her urethra. Then you're going to have her bear down or cough, and you want to measure the angle that the cotton tip applicator moves. So this is sort of like an imaginary protractor, and you're seeing what angle it works at. So if this is horizontal and the Q-tip is in her urethra, just so it's suspended and not falling out. Then you have, so this is the cotton tip applicator. Then what you're going to do is have her bear down, and you want to measure how much that swab moves from the midline, or 0 degrees. What you want to do is evaluate greater than 30 degrees is indicative of urethral hypermobility. And this is a documentable test to help validate what type of stress urinary incontinence she has. Another invasive study is the urethral profile study. During urodynamic studies, pressure flow urodynamics, which are putting a catheter in the bladder and the rectum and evaluating what the bladder is doing in conjunction with the pelvic pressure. As the catheter is slowly removed, it actually looks at the closing pressures of the urethra and evaluates whether or not the urethra is closed. This pressure profile is generated and shows what the peak pressures are and the minimum pressures. This can be calculated to help decide what type of stress urinary incontinence a patient has. The final urodynamic study that's done is abdominal leak point pressure. Once again, this is a pressure flow urodynamic study. A small catheter is placed in the bladder and one's in the rectum. The reason we put the 2 catheters is the bladder does not function in and of itself. We can't just take the bladder out and evaluate what the pressures are for filling and emptying. So what the computer does is take the pressure of the bladder, subtracts the abdominal pressure, and that's the true bladder pressure if it was sitting out in space, completely independent of any other organs. So what happens with this study is the patient is filled to a moderately filled position, usually around 150 cc's, and then the patient does provocative maneuvers. The technician regards the perineum for evidence of leakage, and then at the same time will chart that on the computer. That pressure is then calculated, and it will help to decide if it's less than 60 millimeters of mercury, greater than 60 millimeters of mercury, or greater than 100. And this will help annotate and decide what type of surgical or non-surgical management will help alleviate the patient's problems. So how do we manage it? So actually there's inadequate urethral resistance. It could be due to weak muscles, loss of anatomical support, reduced estrogen, or a nerve problem. And the leakage can be severe to very mild. Some people may not be bothered by it at all. I've had a patient come into the clinic and say, you know, they've had it, they can't handle one more drop in their drawers. The financial cost may be so burdensome that they decide it's now time to get help. So, excuse me, the treatment options obviously are, if it's a muscle problem, doing exercises. Pelvic floor muscle activity is one of the easiest ways to address weak pelvic floor exercises. As I've said before, these are not the exercises we learn in gym class, although many of the different types of exercise we do today actually has pelvic floor strength component. For example, Pilates, belly dancing, and yoga. Looking at the improvement of the core strength also helps the pelvic floor strength. So what you want to do, first of all, if the pelvic floor is not strong, we need to get it stronger. You wouldn't expect somebody to hold a 100-pound weight with their bicep if they hadn't used their bicep for years. So you gradually work up and then add exercises. We could also do things like increasing the resistance. How do you do that? By improving the pelvic muscle strength. But if there's no nerves there, it's not going to work. So there's different ways of improving the muscle strength if the nerves are intact. We can do intravaginal or interanal electrical stimulation. What this does is stimulate the muscle to contract and actually improve strength over a period of time. Typically, the patient will come to the clinic and have an electrode placed in their vaginal or anal vault, and a small, just slightly stronger than a mosquito bite buzz will stimulate the contraction of the muscle. This also helps patients who have difficulty eliciting a squeeze because they don't know how to squeeze the muscle. Sympathomimetic drugs are also used, although this is an off-label use. Currently in the US, there are no meds indicated for stress urinary incontinence. In Europe, SNRI depression drugs are actually indicated, but due to the black box warning, the FDA has not approved them in the US. If a patient has depression and stress urinary incontinence, discussing with their primary care physician or their psychiatrist to augment their depression with one of these drug classes may actually have some off-label benefits. Pessaries. These are intravaginal plastic devices that are placed in the vaginal vault and actually apply a kink to the urethra to increase the resistance. The pessaries are removed typically once a week to be washed, and they can be used with or without during intercourse. So that will be one of the deciding factors whether or not this is a good option for a patient. Vaginal weights and wands are actually devices that are placed in the vaginal vault to help patients to improve their vaginal strength. These weights or balls can be obtained from different XXX stores, but they also can be obtained from www.middlesexmd.com. A lot of patients are not willing to go into these stores to get them, although their popularity is being heightened after the Gray books came out. I can't think of the title right now, but a lot of my patients asked if it was the same devices that the protagonist in last summer's hit series, Gray, was using. I told them yes, that some of those devices are similar, but there are also medical devices that are paid for by insurance that you can order through with a prescription from middlesexmd.com. This is a discreet website developed by a female physician who also has a storefront where you can buy these devices and have them mailed to your home without the fear of having your neighbors know what's in the box. Finally, there's urethral inserts. These are devices that can be put into the urethra to increase the resistance. They're changed out typically every 2 to 4 hours, or an external clamp can be used on a man to actually clamp down the urethra and cause the urethra to coapt. There's different sizes, and many of these products are available from insurance companies and are paid for. These devices may be stopgap measures until a patient is surgically able to have the urethra repaired. Surgical options for genuine stress incontinence include retropubic suspension procedures and midurethral slings. So what happens is a sling is passed under the urethra to cause a kink. It can be attached to the abdominal wall or to the through the obturator fossa of the pelvic muscles, and what can happen is that increased resistance can help stop the stress urinary incontinence. These are very effective mechanisms for people who have genuine stress urinary incontinence. Post-prostatectomy stress incontinence is damage to the nerves in the urethra and scar tissue formation, and this can reduce the urethral resistance in men with activity. They too can benefit from SNRI drugs. serotonin and norepinephrine increase urethral resistance. And once again, they can also have surgical slings. These slings are not quite as readily available as the women's slings, but are also available for stabilization. The next type of incontinence is overactive bladder or urge incontinence. This is a relatively new term, overactive bladder. It can be wet, which is where you're leaking, or dry, just that urgency frequency. This is popularized by pharmaceutical companies with their leaky pipes commercials, or the gotta go right now. What happens here is the bladder is dysfunctioning and it's failing to store urine. It thinks that it's actually full and it contracts inappropriately and unable to, it acts full when it has relatively low volumes. So when you're looking at a bladder diary, these are the people who are voiding 100 cc's every hour and are not able to make it to the toilet. They say that they've got to rush, or the urine is running down their legs. Some of the causative factors include upregulation of the sensory nerves. This may be, we don't really have a grasp why this happens, but some nerves are much more receptive to it. They change in the bladder muscle itself. We see a lot of overactive bladder symptoms in men and women as they get older, and it could also be altered levels of neurotransmitters. We really don't know exactly what's going on. So what are the signs and symptoms? It's urgency, that inability to delay voiding. And they may leak or they may make it to the toilet, but they just have to go. They have to go greater than 8 times in a 24-hour period, or their usual interval is less than 2 hours. Now, one of the caveats here is you always want to make sure that you look at what their fluid intake is. If they're drinking every hour a large amount of fluid, what goes in must come out. So if they have a high excess amount of fluid intake, that could also be contributing to frequency and is actually not overactive bladder. It's just the bladder doing its job. They usually have low voided volumes, and it's the triad of nautria, urgency, and frequency. These people also have the key in the door syndrome. What happens is the bladder, instead of waiting for the brain response, it actually responds to any time that you're near the toilet. For example, coming home from a shopping trip, you put your key in the garage door and your bladder starts squeezing. It's not socially appropriate, but it has to go. It's also seen with a lot of people while washing dishes or hearing running water. It elicits a contraction and they actually go in response to the stimuli. A lot of times in the elderly, the detrusor hyperactivity can be associated with impaired contractility. And that seems kind of weird, like why is it not, if it's contracting when it shouldn't be, why is it not contracting volitionally as much as it should be? And so what happens here is the patient has urgency and frequency. They have to go all the time, but when they actually have a volitional contraction, it's not enough to empty their bladder and they have an elevated PVR. So how do we check for overactive bladder or urge urinary incontinence? Typically, you want to base it on a clinical signs and symptoms. Do they have the triad of urgency, frequency, and nautria? Are they getting up more than 1 to 2 times per night? And typically that's a 90% predictive value. Then we can also do urodynamic studies and look to see if they've actually got involuntary bladder contractions when their bladder is not full. So how do you treat it? Obviously, you're going to treat all the diaper symptoms, but then you want to retrain the bladder. The bladder's gotten used to going every hour and emptying when it's not actually full. So what we want to do is stretch out the detrusor muscle to volumes that are adequate and void by the clock, not by the urge. We also want to do pelvic floor exercises which stimulate the reflect arc and have the bladder relax when the pelvic floor is contracted and squeeze when the pelvic floor is open. We can also do E-stim and medications such as anticholinergics, oxybutynin, and tolterodine. There's also, currently we can also do Botox, and we'll talk about that in a little more detail. The next type of incontinence is combined stress and urge. And this is a stress pattern when there's increased pelvic floor activity, and the urge pattern, which is a sudden need to go when you aren't able to delay it. So this is the type of person who may show both signs at different times. They're like, I'm wet all the time. The patient reports symptoms of stress and urge, and the treatment plan must coordinate both stress and urge treatment. Typically, you start by treating the one that's the most bothersome. If the patient finds that the urge to go is disrupting their work environment, you may want to address that before the stress, which is only happening when they're jumping on the trampoline with their grandchildren. The next type of incontinence is functional incontinence, and this is secondary to mobility problems or cognitive decline. And this is typically continence at regular intervals. So the person may be able to hold it sometimes, but then they become confused and wet their pants. This is done with exclusion of all the other criteria. Sometimes they may have functional incontinence superseding another type of incontinence, but the functional incontinence if they have mobility issues and cognitive decline also. So how would you manage this? Since it's at regular intervals, you want to schedule intervals of voiding. So in a long-term care facility or a nursing home or something like that, having the A's actually physically take the patient to the toilet and toilet them at an interval may help them be able to empty their bladder in the toilet versus in their pants. Prompted voiding, reminding people to go before an episode. This, we've all done this as children. I'm sure you remember your mom saying, I want you to go to the toilet before we go on the road trip. I don't care if you don't have to go to the toilet. This is a type of prompted voiding. We put the person on the toilet and ask them to try. That way the bladder is empty before the next activity. Sometimes the situation may be so dire that the only, due to help or the workforce, we're not able to toilet them as often as we'd like, and we actually have to use absorptive products, an indwelling catheter, or adjunct with the anticholinergic medicines to increase the interval between voiding. Overflow incontinence. The causes of overflow incontinence are BPH in elderly men, pelvic organ prolapse in women, or reduced muscle contractility, for example, a neurological problem or diabetes. So what this is actually retention with or without leakage. So what's happening is the bladder is not emptying adequately, and they may leak with very small volumes because just the top of the bladder is emptying. So if you imagine the bladder, this is the bladder, and it's full all the way. And at a certain point, what can happen is the reflex arc is activated because the bladder is full, and it actually, the bladder will squeeze, and the pelvic floor will open, and a small amount of urine will escape. This is typically seen in people who have paraplegia, but when you do an ultrasound or a post-void residual check, you actually see that they have a large amount of urine remaining in their bladder. The symptoms are frequency and urgency. If they have sensation, if they have a neurological deficit or a spinal cord injury, they may not have any of that sensation, but actually have just frequent bedwetting or underwear wetting. They usually have small voided volumes, increased nautria, and feelings of incomplete emptying if they have an intact spinal cord. All in all, they will have elevated post-void residuals, and sometimes they'll have suprapubic tenderness. How do we address this? First of all, we need to diagnose the post-void residual. Then we need to evaluate whether it's a bladder problem or a pelvic floor problem. Is the pelvic floor actually relaxing and opening? and is it coordinated with the squeeze of the bladder? Sometimes just eliminating the cause, like bladder BPH, opening up the prostate, can actually increase the ability for the urine to escape the bladder because the channel's open. By physically putting the bladder back in place for pelvic organ prolapse can decrease the kink in the urethra and allow the bladder to work coordinated. Time voiding and double voiding can also be used, but this is for mild retention, and the upper urinary tracts are not in danger. Electrical stimulation or InterStim, this is neuromodulation, and there's been some work at stimulating the S2 to S4 nerves with an implantable device, and it actually can provide stimulation and have the bladder work. Ultimately, our main goal is to preserve the upper urinary tracts. The kidneys have to be preserved, and we do not want reflux or chronic urinary tract infections. So emptying the bladder is imperative. We want to try and teach people how to clean intermittent cath if possible, and as a last resort, to do an indwelling catheter. The next type is neurogenic bladder. This is on page 36. This is total loss of voluntary control in a patient with a spinal cord lesion above the spinal cord level, or and what happens is the bladder empties by the reflex arc. This is called detrusor hyperreflexia. What happens is they have a supraspinal lesion, so they don't have any awareness and no bladder control with emptying or filling. And so what happens is the bladder just squeezes and it empties without coordinating with the brain. This can actually be also seen in patients who have multiple sclerosis or spinal cord lesion. The problem with this is you can also have bladder sphincter dyssynergia. When it's working properly, the bladder relaxes, the pelvic floor, the sphincter squeezes. When the bladder is squeezing, the pelvic floor opens. What happens in this, the coordination is off, and so bladder sphincter dyssynergia or detrusor sphincter dyssynergia, it's the same thing. It's the muscle of the bladder is not coordinated with the sphincter. What happens is the bladder squeezes, the pelvic floor squeezes. So the bladder is squeezing against a closed door. When the bladder is relaxed, the pelvic floor opens. So this lack of coordination can have inadequate emptying of the bladder, and also can cause increased pressure in the bladder, which will cause reflux to the kidneys. Anybody who has a neurological lesion needs urodynamic studies first. Condom cath in men, if they have no evidence of an elevated post-void residual. Clean intermittent catheterization with the adjunct of oral antimuscarinics can also help keep the bladder coordinated and emptying on a schedule. Last resort is an indwelling catheter or continent urinary reversion. Please excuse me, I missed page 35, total incontinence, pathology, presentation, and treatment options. This is when you're just leaking all the time. Typically, this is secondary to a ectopic ureter or a fistula. This is a communication between one of the pelvic organs and part of the bladder or the urinary tract system, and the urine is leaking all the time. This can be secondary to a trauma, to typically a traumatic birth. This is seen a lot of times in developing countries where young women are giving birth at very young ages and sustain pelvic trauma. It can also be seen after surgery with somebody who develops stress incontinence after, who develops severe incontinence after pelvic surgery, such as a hysterectomy, where there's a hole artificially made in the bladder and it connects to the vagina. It can also be secondary to pelvic radiation or seed implants. These people usually need to have it repaired, and if surgical repairs, they're not candidates, absorptive products. Enuresis. This is wetting the bed after the age of 4 to 6, or a toilet-trained child. There's many different theories of why children develop enuresis. Sometimes it's secondary to the maturation of the neural pathways. These children actually get into such a deep REM sleep that they don't wake up and they don't feel the urge to void. They may have inadequate production of antidiuretic hormone, and this results in nocturia. There also has been a correlation between a genetic link, as many parents who had this problem as children also have children develop it. So how do we manage it? First of all, you want to rule out that there's not another problem, that the child does not have a neurological problem that has been undiagnosed, or they're not having recurrent urinary tract infections. Sometimes they can develop tags or other problems with the urethra during the embryonic development that doesn't present itself until after they become toilet trained. So usually it's persistent bedwetting and a lot of times alarm therapy and behavior modification. Parents or caregivers waking up the child to toilet at at intervals throughout the night. You can have a bed alarm, which actually when a drop of fluid gets on the alarm, it sets off the bed, which can either vibrate or wake the child up with a sound. Hormonal therapy with DDAVP, and counseling the child and parents to look at this and helpfully work through it together if there's no primary treatment. A lot of times it's no one's fault, and you want to make sure that the team is working together so that the child, as they develop, this is not something to scar them. So that's the end of looking at an overview of when things aren't working. So once again, in summary, you want to look at it. Is it a bladder problem or a sphincter problem? Is something making the bladder squeeze when it shouldn't, or not squeeze when it should? Is there something blocking the urethra or the sphincter from opening when it should, or is it opening when it shouldn't? So when you think of it that way and just look through it, that might be very helpful. In your appendix, on page 193 to the end of that appendix, 212, we actually have algorithms that the International Continence Society has put together to help you look at these different factors. We're going to go over these in much more detail as we review the initial management. But this is looking at the initial management, how to assess someone, and what the different management, the presumed diagnoses, and the treatment are. This may help you, this algorithm. You might be the type of person who likes to see things in an orderly fashion, and this may help you. You may be the type of person who looks at a flow chart and just feels all discombobulated. This is just here to add to your learning exercises if you so choose. Also, there's a nice overview of all the different urinary incontinence types in your page 225, appendix 11. This is a chart that looks at the different types of urinary incontinence, the type of dysfunction, the etiological factors, the clinical presentation, and the management options. Obviously, we've just looked at the different types and we haven't gone into much detail about the management options, but using this chart and setting it up this way will also help you as studying. I also recommend getting cue cards. On one side of the card, write the type of incontinence. On the back, write the etiological factors. And quiz yourself and see if you can do that. Also, write the type of incontinence, and on the back, what is a management option. And that way, it will help you delineate what's going on. I hope you too will enjoy the continued knowledge of incontinence, and thank you for listening.